Yeah, my case is very similar to Dr. Lakshmi's case. I did not know she's presenting this. Anyway, slight differences are there. This is a 50-year-old gentleman, not even 50, he's 45. He's a chronic smoker, non-diabetic. He presented with intermittent claudication and okay. Yeah, that's it. That's it. Thank you. So this is the, I did not bring the diagnostic angio. This is the first shot which we gave with the hand injection, showing complete occlusion of the aorta just below the renal arteries. And this again shows the same thing. And he had, of course, reformation of the aorta little above the bifurcation. Yeah, you can see that the bifurcation is intact. So it's a length of about 60 millimeters or so. The vessel is occluded, and we of course put a sheath from below, from the right groin, and from the right brachial, right radial sheath, and we attempted to cross it. We were prepared to cross it from above in case we are not successful to do it from below. And we used, of course, one of the wires we used is a Shinobi wire, the other way Miracle 14 wire. And you can see this is the simultaneous injection from both sides. A lot of contrast was used in this patient, nearly 400 ml at the end of the procedure. This the wire that has crossed, but obviously this is not in the proper lumen. And this is the Miracle wire, and you can see one more attempt was made to pass another wire, but finally we actually got it from above only. It's a Shinobi wire. Finally we crossed from above, and Miracle, we tried both. Multiple times we exchanged it. We used, of course, a microcatheter, and the microcatheter went all the way down, and through that when we exchanged it, we got it. Yeah, that's the microcatheter. We removed the wire finally once we got into the distal part of the aorta. The injection shows the contrast is clearing quickly, indicating that we are in the true lumen. And this, of course, is the wire once again. This is the Miracle wire once again. We got it out of the right femoral sheath, and then passed a right 5 French Judkins coronary catheter that went through over this wire in the reverse direction into the ascending aorta without much problem. The patient, while passing this catheter, had, of course, considerable pain and vasovagal syndrome. You can see that the right Judkins 5 French catheter is in the descending aorta above the occlusion. That's the catheter. Then we exchanged it with a Amplage extra support wire, 3-5 wire, dilated it at multiple levels. And this is the pigtail injection, which is showing the total length of the occlusion. And then we did not have one stent that would cover the entire length. So we had to put 2 stents. One is a 14 millimeter into 40 millimeters, 14 into 40 self-expanding stent. And there is a Johnson & Johnson stent. The next one is a 10 into 40 millimeters. Yeah, the stent is already in place. It was not expanding for, you can see that a part of it has not opened up, but then we said we will completely dilate it after we put the next stent. This is the second stent coming up. Both are deployed. And that is a 12 millimeter balloon at the junction of the two. That's the final result. So there is some degree of, you can say, radiolucency here in the center, but I think his femoral pulses have come back very well. We did not use any thrombolytic therapy in this case, and he's doing fine, and despite the large amount of contrast we used, we had there's no renal shutdown or contrast-induced nephropathy.
He was symptomatic for how long?
For 6 months. He stopped smoking only about 20 days before he got admitted. He was with...
Again, somebody asked in the previous case, did you use thrombolysis?
No thrombolytic therapy, because I am convinced it's a chronic thing. I know there are reports of successful thrombolytic therapy in chronic thrombus also, but in this case we got it along without much problem. Is of course, almost all these cases we give 3 antiplatelets. We add cilostazol to most of our patients, going by the Korean trial. I think it makes a lot of sense. We have some patients of acute stent thrombosis, so it's in peripheral vascular, there is no question. Peripheral vascular disease, cilostazol is a must. So we use it in all patients.
For the argument's sake, somebody wants to ask you, can you find out whether it is thrombus or something else by CT angiogram? I mean, is it possible to predict?
Well, I have no doubt that what we have here is a thrombus, a smoker, young fellow, and there is no other reason.
Whether it is organized or fresh, which can be dissolved, that is what is the question.
It's a relatively old thrombus, not probably very old. So aortic crossing aorta is always a total occlusion like this. This is not the first case. They are mostly rewarding and they open up fairly.
The radiologists here, they all claim that they can tell us whether it is thrombus or whether it is...
Sir, rather than the radiologist, as a surgeon, I will be able to tell you, because I have opened more than 50 like aortas like this. So most of these thrombus, when we open these aortas, they are chronic thrombus, what you are suggesting. And that's why sometimes they are very difficult to cross and sometimes they are very easy. What I wanted to ask you a question was, I am always scared when there is a blockage at the renal level. So what happens is, from outside it's very difficult to detect, is there a soft material inside or not. And if it is a very calcified material, I am not worried. But if it's a very soft material, I am very worried, because that can go into the renal arteries. And when we do an open surgery, that's the only thing we are worried about. And that's why we sling both the renal arteries first, so that embolization does not happen to the renals. And I have actually lost one patient because of that, really. And being very, very careful, like long time back, 5 years back, I lost one patient just because of renal failure. He had a cholesterol embolization, both sides, very, very soft plaque. But most of these patients, they have got calcified material, but they are soft. I have never tried endovascular at this step, and I was just thinking, like, how much experience you have in this particular group, and do you find some creatinine which goes up subsequently in 1 or 2 days? Maybe because of the contrast, I don't know, but maybe because of cholesterol embolization, or I'm always worried when we do an endovascular in such a situation.
Yeah, there's no doubt that if you have soft material, it can go into... We had a patient, in fact, we lost her due to renal artery embolization. But that was, I do not remember exactly whether, how far the renal arteries were in relation to the occlusion. But that lady had marked embolization to the lower limbs, developed the syndrome of fat embolism, and went into renal failure, and finally we lost her. We discharged her after what looked like a successful angioplasty, came back with multiple ecchymosis over lower limbs and renal failure, and lost her. But in this particular patient, I was very confident, because the renal arteries are well above the site of occlusion. And the stent we used is a self-expanding stent where there is no graft or anything. We are not worried about occlusion. We had quite a few patients of aortoarteritis in whom these vessels, of course, they were not total occlusions, but 99% long lesions. In fact, we are scheduled to do one more patient this week. They seldom develop any consequences of renal artery lesion. If you put the balloon across the renal artery mouth and dilate, then of course you may get into trouble if it is atherosclerotic aorta.
But arthritis, I am not worried, because we open up the arthritis patients also. Sometimes when we do open surgery, I am not worried at all.
Yes.
Because nothing is there inside. They are very smooth.
It is atherosclerosis,
it is atherosclerosis
which problem.
I am worried. Yeah.
We had a patient of aortoarteritis who had a renal artery lesion also, just adjacent to this. So we wired it, we protected it. Despite that, it developed narrowing after the stenting. Then we put another stent through that.
All right.
Thank you.